This podcast is brought to you by the Pacific Neuroscience Institute Foundation. It only takes 1 month to change the rest of your life. Support a healthy brain and resilient memory with PNIF's new lifestyle program, available virtually and in person. Limited spots are available. Find out more at pacificlifestyle.org.
Hello, this is Anthony Effinger. I'm the host of the Think Neuro podcast from Pacific Neuroscience Institute. And today I am talking with Dr. Melita Petrossian. She is a neurologist, and she's going to talk to us today about some interesting work on essential tremor. Thanks for joining us.
Thanks for having me.
So this is at least your second appearance on the longer form podcast, and we're really glad to have you back. Tell us a little bit about what you specialize in before we get on to essential tremor.
So my specialty is movement disorders, which refers to neurological conditions that affect involuntary movement and subconscious control of movement. Majority of what I see is Parkinson's disease, but I also see other causes of tremor, essential tremor, dystonia, gait disorders, ataxia, myoclonus, and tics.
Interesting. When you say subconscious control of movement, what does that mean?
So when you get up and walk to your fridge and grab a glass of water, you aren't consciously thinking about your arm swing and your flexion and extension of your knee and how that alternates between right and left. All of that is being controlled by a part of the brain that I like to call the autopilot. Which really just manages the size, speed, smoothness of these subconscious movements. I would say probably at least 98% of the movements that we make in our day-to-day are subconscious, unless somebody's a dancer or something like that. We really are relying on our autopilot to make the movements in our face, make the movements that create our voice. We're thinking about more important things than how our body is moving.
Where does this autopilot reside?
It's in the part of the brain called the basal ganglia. So it's deep inside the brain, sort of near the midline, adjacent to the brainstem.
So is this is a pretty primitive structure, I imagine?
Yes.
I mean, movement is an essential thing. And the bottom line is if we had to think about all that movement in our conscious mind, we really couldn't think about anything else, right?
Exactly. It causes a lot of cognitive load to have to consciously think about how to move, the arm and the leg. The analogy I like to give is when you're learning something new, you have to use your conscious mind to control the movements. And then once you've done that thing well enough for it to become what's called muscle memory, then that means your subconscious mind has taken over. The motor program has been written into the basal ganglia, and all of that just happens smoothly without much conscious thought.
The motor program has been written into that tells you, at least tells me, we're very much like computers in that sense. Like the code just runs, right?
That's right. In a normally functioning brain, the program gets initiated and then continued and stopped without really any conscious input.
Is this what we call reflex?
No.
Or is that something different?
No, I mean, I think the way to put it as for lay people would be like reaction timing. But it's more than just that. You're walking down the street, talking to a friend, you get to an intersection, you stop. The light turns green, you go. You don't have to tell your brain to do that in a conscious way. Reflexes, what we refer to as reflexes, are the deep tendon reflexes, where when we elicit them by striking the tendon with a hammer, that's all spinal. That has nothing to do with the brain, really.
Okay, got it. What about when is this when an athlete trains over and over for, say, a gymnast, are they trying to write that into the basal ganglia or no?
Yes. When an athlete is training, that's exactly what they're trying to do, is trying to initially break down the movement, think about it in a conscious way, and then try to get it to a point where it, as they say, comes natural, where it doesn't require so much conscious thought. The analogy I always like to give is I grew up skiing. And then when I was a teenager, all the cool kids were snowboarding. So I thought, okay, I'll try to learn how to snowboard. And every time I would go up, I would have to really focus and concentrate and figure out what I was doing with my toes and my heels and try to balance and all of that. And then eventually I said, I just enjoy skiing so much more. So I went back to the skis and I said to myself, oh my God, this is just so natural. I don't even have to think about it. I just point my skis and they go. But in reality, it's because I'd been skiing for so much longer that it had become subconscious by virtue of all of the times that I had to, think about what I was doing. And it was no longer the case.
Certainly. Yeah. Yeah. I grew up as a skier as well. And I tried snowboarding about 3 times and that was enough. For mostly because I was hurting myself. So you tell us, you see what happens when this autopilot goes wrong. That's correct?
Yes. So in the case of Parkinson's disease, the autopilot doesn't work as well, and people's movements become slower, stiffer, less smooth, less regular, smaller. And there's another aspect of the motor control, which is called the basal ganglia, which is suppressing tremor movements. So what's odd is that our brain actually has tremor generators in a part of the brain called the thalamine, or thalamus singular. They're very tiny little nuclei of cells. A nucleus is just a collection of brain cells that are located one on each side. And weirdly enough, they actually generate a tremor in our brain. And what naturally happens is the back part of the brain, which is called the cerebellum, suppresses the tremor that's generated from these tremor generators. The way I would describe the tremor generators is that if I try to put my hand out, there's a force that's flexing the wrist and extending the wrist. And that's happening kind of like a sine wave, where it's just going flexion, extension. But if you look at on a regular day, let's say, it's happening so quickly as to be microscopic, as to be not visible to the naked eye. When you have had a lot of coffee, or you haven't slept well, or you've taken a stimulant of some kind, or sometimes just with extreme anxiety, you will see that tremor come out. You'll see that tremor generator in place in the form of the more obvious or apparent flexion, extension in a rhythmic way. But people who have essential tremor, the cerebellum, as I said, isn't working as well to suppress that natural tremor that's coming from the brain.
It sounds like the cerebellum in this case is almost like a steady cam feature, or I think we have it on our iPhones even. It's like, do you want to smooth out the motion? Because there is that is that sort of what we're talking about, is regulating this tremor that has to exist in order for us to do things like extend our arms? I mean, the tremor.
That's a really great question. I love that analogy you gave of the Steadicam, or the software that is a tremor stabilizing software, as the role of the cerebellum. I'm not sure if I would say that, why is there a tremor generator? Like, is that necessary? I think it just maybe has to do with maintaining a posture and having that push-pull, because I guess the concept being that it would be challenging to send signals of simultaneously, exactly at the same time having flexion and extension. But yes, the cerebellum has many purposes. The main one is making movements smooth. So if you've ever looked at a newborn baby, or, like say a 3-month-old, the movements are really jerky and fast and kind of almost twitchy. And as the brain is developing, that cerebellum starts to smooth things out and the movements become less jerky and wobbling.
Yeah.
Another great way to think about what the cerebellum does is to imagine, and I'm sure this has never happened to you, nor to me, but to imagine intoxication with alcohol. Because alcohol basically suppresses the function of the cerebellum. So people stagger, people veer, the room starts to spin, things like that. The speech gets slurred. But there's also changes in emotional regulation and cognitive regulation. So there's actually a lot that the cerebellum does. It has multiple pathways.
Does alcohol affect the cerebellum more than other structures in the brain?
Yes.
Or is it just where we notice it first?
No, I think it affects it most noticeably there.
Interesting.
And not just acute intoxication, but also with chronic use of alcohol, the most prominent area of degeneration or atrophy is the cerebellum.
Fascinating. Those cells just tend to be more susceptible to the ravages of alcohol.
Yeah, there's the cerebellar cells are more susceptible to alcohol and other toxins. And unfortunately, once those cells are gone, they are gone. So, when people have had a life of chronic excessive alcohol intake, there's not really much to reverse that other than prevent it from getting worse.
Yeah, and this is why, very chronic alcoholics are shaky, right? If they're not.
That's right. Yes, it can exacerbate tremor. Now, what's really weird about alcohol and tremor, and we'll get more into talking about essential tremor in a bit, but people with essential tremor will very typically notice that when they have a glass of wine or a drink, they will actually notice that their tremor will stabilize. And then they can sometimes run into the problem of self-medicating. So when they drink to stabilize their tremor, they will then find eventually that the tremor gets worse. Sometimes the tremor is worse the day after when they wake up in the morning, and sometimes it's more of the chronic tremor just getting worse over the decades.
Do we know why alcohol has that effect on essential tremor?
Alcohol triggers the GABA neurotransmitter, which is the more calming, sedating side of the neurotransmitters.
And that has an effect on tremor.
And that reduces tremor.
Okay, so let's talk about essential tremor and why we call it essential tremor.
That is a wonderful question. Why on earth do we call it?
It sounds like something we need.
Can I tell you how many people have come in telling me that they've been diagnosed with non-essential tremor, unessential tremor, unintentional tremor, and none of that is the right word. It's just such a bizarre terminology. So essential tremor means that the essence of the condition is tremor. Essential is a medical term for primary, or it is what it is. So tremor is what it is. Tremor is the essence, hence essential tremor. Another example of the use of the word essential is the medical condition essential hypertension, which refers to when people have high blood pressure, and it's not because of their kidneys not working. It's just they're getting older and they have high blood pressure. High blood pressure is what it is. It's essential hypertension. But people get really confused by that term, essential tremor, because they think, why should I have this? Why would it be essential for me to have this? And it's just really not the same use of that word essential.
Yeah.
Sometimes people will come to me and they've been told that they have benign tremor or familial tremor. Sometimes people will say familiar tremor, which is also not a thing. But benign tremor, familial tremor, benign essential tremor, these were previously terms that we would use, but we dropped the word benign because it turns out that a not small percentage of people with essential tremor do go on to have quite disabling tremor. The term benign was used to differentiate it from Parkinson's disease because it doesn't carry as many of the other symptoms of Parkinson's, such as shuffling gait, difficulty swallowing, or cognitive decline. But as I said, it can get to a point to be disabling and very problematic for many patients. And therefore, we stopped calling it benign.
Okay.
We stopped calling it familial tremor because it doesn't always run in the family, but it is very common to run in the family. Another term that people will have heard is intentional tremor, which again doesn't mean that the person is causing the shaking intentionally, but the concept being that on exam, the tremor gets worse as the finger is nearing a target. So intending to get to a target, people will notice that, for example, as they are holding a cup and bringing it to their lips, they might be okay, not too bad. And then as they get closer to the lips, the hand will shake more. So that is just a description of tremor getting worse as one is nearing a target, is not a diagnosis. It's just a description. The concept is that there's different aspects of the tremor that we look for on exam and by history. We are listening or looking for a postural tremor, which means when the limb assumes a position, the tremor is present immediately upon assuming the position. So examples of that in somebody's life might be when I hold the newspaper, my hands shake. First, nobody holds the newspaper anymore. It's usually as I'm holding my smartphone, my hand that's trying to reach, my hand that's holding the smartphone is shaking. Or I'm holding a cup and my hand is shaking. I'm holding a plate with one hand and my hand shakes, so I have to use two hands. Action tremor refers to tremor when moving the limb. So for example, the reaching out, touching the smartphone, typing, shaving, putting on makeup, handwriting, using a spoon, pouring liquids, etc. All of that is action. So what we look for on exam is typically what we do is have the person hold their limb out one at a time, outstretched in front of them, their arm, and then with the elbow bent at an angle with the hand up next to the chin. And then we'll have them, touch their nose, reach out and touch the examiner's finger back and forth, that kind of thing. And I will always look at somebody's handwriting when I'm evaluating tremor. Handwriting is incredibly helpful to me because not only can I see the tremor, but I'm always trying to rule out Parkinson's disease. Anytime I see somebody with tremor, I'm always thinking, could there be a possibility that this is Parkinson's? And I know that's what they're thinking too.
Yeah.
So I'm always looking for that. So if I see that the tremor is happening more at rest, meaning that when the limbs are fully relaxed. So for example, they're sitting in the chair with their arms on the arms of the chair and their hands are just dangling. And then I see the tremor on one side, or I see a tremor in the leg when their feet are relaxed. That would be more concerning for a rest tremor, which would be more seen in Parkinson's. And then I'll look at the handwriting. And if the handwriting is getting small as they go, that is more concerning for Parkinson's. So when I see big sloppy handwriting and, they're changing the handwriting to be bigger to accommodate the tremor, that tends to be reassuring that it is essential tremor.
How common is essential tremor and when does it tend to come on?
Essential tremor is very common. It affects about 8 million Americans, which is about 8 times as many as Parkinson's disease. And yet nobody's ever heard of it. Whenever people think tremor, they think Parkinson's. But essential tremor, it is the most common movement disorder. It's the most common cause of tremor. And it is something that a lot of patients just need that reassurance that that's what it is, essential tremor. It can come on at various times of one's life. So there's what we call a bimodal distribution of the age of onset. For some people, it starts in their 20s or 30s. It can even start younger in one's teens, and there are even pediatric onset of tremor, of essential tremor. And for people where the tremor begins in youth, they are much more likely to have a family history of essential tremor. And then there is another group of patients who develop tremor in later decades, in the 6th, 7th, and 8th decades. And in those cases, it doesn't necessarily always run in the family. When it comes to ascertaining a family history of essential tremor, many patients really just aren't aware. And the reason why I know that is because I will ask them, do you have a tremor? And they will tell me no. And then I will look at their hands and they have a tremor. So I'm thinking if they don't even recognize their own tremor, chances are people may not always recognize tremor in their family.
Sure. So what's happening? What are the causes of essential tremor? There's something's going wrong in the cerebellum, right?
Yes. It's not as well understood what causes essential tremor compared to the work that's done on understanding the causes of Parkinson's disease. But the gist of it is that there is dysfunction in and degeneration of some of the cells in the cerebellum, and that results in a reduced outflow to the thalami, the tremor generators in the thalami, and an increase in the tremor coming from the thalami.
Is dopamine involved at all here, like it is in
Dopamine
Parkinson's?
is not involved.
Not involved.
Not relevant
Okay.
to essential tremor.
But it is with Parkinson's.
That's right. Parkinson's is the degeneration of the cells that create dopamine.
Right. Okay, so no dopamine involvement here.
Of those cells in essential tremor.
Okay. And is essential tremor something that if you have it, you can live with it? Does it get worse the way Parkinson's does?
That's a great question. Essential tremor very typically does get worse over the decades, but it's a very, very slow progression. So somebody may have onset of tremor in their 20s and be completely functional and may not even seek treatment until they're in their 50s or 60s. But many people adapt and find a way to live with it. What's interesting is sometimes patients will have a stabilization of their tremor for many years, and then it'll get worse again a little bit, and then it'll stabilize again for a few years. So many people find ways to live with or cope with the tremor. Other than tremor, the other symptoms of essential tremor include balance issues. So people can have difficulty with walking and rarely trouble with their voice. That is to say, there can be tremor in the voice. That's not rare, but other types of voice issues can also occur. But other than those two things, really, it's just tremor. So, people find ways of coping with it. It's not a muscle disease. It's not a nerve disease. They're not getting weak. So in many cases, it's very livable. Now, somebody who gets tremor in their 20s might choose not to become a surgeon, for example. But there are professions where they are going to find it more disabling, even with a mild tremor, than, quote unquote, the rest of us. So, for example, a surgeon, a dentist, a jeweler, these are people who may find it more challenging to cope with tremor, even when it's mild. In addition, people who are in the public eye, actors, politicians, public speakers, etc., they may have difficulty tolerating the tremor simply because of the social implications of it.
Sure.
Which is why I'm glad to have this opportunity to talk about essential tremor today, because again, as I said before, nobody's heard of essential tremor. So the two things that people think when they see somebody with tremor and shakiness is either they've got Parkinson's or they're nervous. And the interesting thing about that is that tremor can get worse when people are anxious. Even people who have essential tremor, they very typically will notice that when they're stressed, when they're anxious, when they haven't slept well, when people are staring at them, they will have an exacerbation of their tremor. But they will also have tremor when they're not nervous or stressed, when everything's going fine. They will still have hand shaking or other parts of the body shaking. And therefore, they recognize that they are not having tremor because they are anxious. This is just the condition that they have. And a lot of my patients don't necessarily want to get in a conversation about why are your hands shaking or are you okay? They just want to do their work or, enjoy themselves at their family get together, whatever it is, without having to have that conversation. So I wish more people knew about essential tremor and could stop making those assumptions that, quote unquote, something is wrong. I do find that it's a very challenging thing that my patients deal with, is that this social implication and the decision of whether or not to have a conversation. And I wish more people would just sort of realize that tremor doesn't mean anything sometimes.
Right. And so that's why you work so hard to rule out Parkinson's in tremor patients, right? Both to put the person at ease. I imagine you get a lot of people who are suffering some sort of tremor and think the worst. So you have to rule that out.
I have to say, I have to be honest, I have a lot of patients where they get told for a number of years that all they have is essential tremor. And then I look at them and I say, no, this is Parkinson's.
Okay. So it goes the other way too.
Unfortunately, and not to terrify people, but it has happened quite a bit that they get told it's essential tremor and then it's not.
And then they lose time in treating the Parkinson's.
Yes. That is a concern, definitely, especially
to the extent you can.
Because I'd hope that in my career, I will find FDA approved treatments for slowing down the progression of Parkinson's disease beyond what we know that exercise and other lifestyle choices can do. So I do think that it does make a difference to make an accurate early diagnosis.
Yeah, sure.
There are ways to do that beyond just the clinical exam.
Ways to distinguish.
Yes.
Beyond that. So what else? What can you do?
One of the prior podcasts, I was talking about how we differentiate between essential tremor and Parkinson's tremor. I mentioned earlier that a rest tremor is going to be more likely to be a Parkinson's tremor, and a symmetric postural tremor with action is going to be probably more likely to be essential tremor. I also would be looking for what we call bradykinesia, which means slowness or smallness of movements, and rigidity, which means stiffness or lack of relaxation in the arms. That's my favorite.
That's a sign of Parkinson's, right?
Yes, rigidity and slowness or stiffness are signs of Parkinson's.
Okay.
One of my favorite aspects of the exam to sort of catch the tremor is I ask the patient to get up and walk. So the ease with which they're getting out of the chair, their posture, their arm swing. If I catch the tremor as their arm is swinging, their stride length, are they shuffling? Are they freezing? How are they turning? What's their balance like? All of those things can point me towards Parkinson's, or the lack of any of those kinds of abnormalities will reassure me that it's not Parkinson's. So there are many patients where, even as a experienced movement disorder specialist, that tremor isn't exactly fitting into those boxes. I might find, for example, somebody has reduced arm swing, but they've had a shoulder injury, so there might be reason for that. Or their movements look like they're getting a little bit slow or small, but they have arthritis. So, and for example, some people who've had essential tremor for a very long time may have a rest tremor. We call that a spillover into rest when the tremor is bad enough. And though one might say, well, if they'd had essential tremor for 3 decades, then that's all it is. About 3% of people who have essential tremor do go on to develop Parkinson's disease. And that's compared to about 1% of the general population. So it is a slightly increased risk, only slightly.
Yeah.
So for cases where I cannot differentiate, or I can't really be 100% certain about whether the tremor is a Parkinson's tremor or essential tremor, there are 2 diagnostic evaluations that I can offer. One is called the DAT Scan. DAT Scan, DAT Scan, stands for dopamine transporter. And it is a type of brain SPECT, SPECT scan that measures the level of dopamine in the brain. We don't have any blood tests that can measure dopamine. We don't have any blood tests that rule in or out Parkinson's disease. MRI doesn't do a good job of ruling in or ruling out Parkinson's disease. So the DAT scan is FDA approved to distinguish between essential tremor and Parkinson's tremor, or I should say Parkinsonian syndrome, because that's a whole other conversation, but it doesn't differentiate between subtypes of Parkinsonism. So the DAT scan is available at St. John's and Little Company of Mary in Torrance, and it was FDA approved in 2011. And it does a very good job of distinguishing between essential tremor and Parkinson's disease. It is, as with many tests, it is not 100% accurate, but combined with the clinical exam, it can really help solidify a diagnosis or rule out Parkinson's disease. The other tests that we have available at Pacific Neuroscience Institute for evaluating for Parkinsonian syndrome is called the Syn1 Biopsy. That's SYN1 biopsy. And it is a skin biopsy looking at the nerves of the skin, looking for the abnormal form of the protein alpha-synuclein to evaluate for Parkinsonian syndromes or synucleinopathies more generally.
Wait, this is a skin?
Yes.
How does this work?
It's a 3 millimeter punch biopsy. We do it near the shoulder, near the knee, and near the ankle. And it's very easy. It's just done in our clinic. Our nurse practitioner, Giselle, performs those.
Punch biopsy, meaning you take just a little, you punch out a little.
3 millimeters.
3 millimeters of skin. And you're looking for this protein. What is it?
So an abnormal form of the protein alpha-synuclein.
And is that everywhere in our bodies? Is that why you can detect it in the skin, or?
No, it's in the nerves of the skin.
Nerves. So you're getting nerve tissue.
Yes. Peripheral nerve.
Okay.
So it's not like taking out a whole nerve or a branch of a nerve. It's like really, it's almost like the nerve endings really in the skin.
And you can look at this very small sample of nerve tissue that's in that skin punch out that you take, which is tiny, and find this abnormal form of alpha-synuclein. Okay. And tell us why is that the cause, or is it just a marker, the abnormal form?
The abnormal form is thought to be the cause of Parkinson's disease.
Okay. So that's a pretty good test.
The abnormal form of alpha-synuclein, because it's misfolded, it clumps together. And then it encourages other alpha-synuclein proteins to misclump as well. And that is to say, to misfold and clump. And so those clumps then gum up the works in the cells, and that causes eventually those cells to die. And then that causes the reduced dopamine production.
I see.
Multitude of other symptoms.
Sure. And so the misfolding can start to occur. I guess it starts to occur more often in older people.
Correct. Yes.
Yeah.
Probably the greatest risk factor for Parkinson's and other neurodegenerative conditions is age. Get older.
Yeah. It's just over time, it's gonna. Yeah. What treatments do we have available for essential tremor now? So
there are 4 aspects of the management of essential tremor. The first is what we call non-pharmacological management. So these are aspects that make people's lives easier, but don't reduce the tremor. So a lot of it is essentially, how do we cope with tremor? And many patients will have self-identified these types of things coming in already. For example, they will learn to use 2 hands to steady a glass of water, or they may use a travel mug with a lid to reduce spills. They may find that as they brace their hand, they can shave more easily rather than sort of using just the one hand. There are assistive devices that have been created for people with tremor, and it doesn't have to be essential tremor, it could be Parkinson's tremor, but there's a lot of things that have been shown to help people who have tremor. For example, you were mentioning earlier the tremor stabilizing software in the smartphone. Well, that same technology was put into a spoon and a fork, and it's called Liftware. And as you can go online and find videos of this, it's really fascinating. So the person's hand is shaking and they start using the spoon and the hand is still shaking, but the bowl of the spoon is showing 70% less shaking than the hand. Some people with tremor have difficulty with buttoning buttons or tying shoelaces. So there are magnetic forms that really help for these patients, such as a dress shirt that is made with magnetic buttons, and it looks exactly like a button-down shirt, but no buttons to have to deal with, or a magnetic shoelace as opposed to having to tie shoelaces, or magnets for necklaces, because a lot of women have trouble closing their necklaces. So it can use magnets to do that and not have to stop wearing the jewelry. So all of these are examples of, coping and how to live with it, but it doesn't make the tremor any better. As we move on to the second aspect of management of essential tremor, which are medications. So there are two medications that are what we call first line for essential tremor. And really in the last several decades, there have not been any new medications developed. There are other medications that are used, which we call second line or third line. But frankly, when you really look at the data, they're not particularly more effective than placebo. So I tend not to use those medications because I find that by the time I increase the dose slightly and titrate and make sure they're not having side effects, it's the efficacy is underwhelming. So the two medications that are first line are Propranolol and Primidone. Propranolol is what's called a beta blocker. So if you've heard of the fight or flight response, the sympathetic nervous system that increases our heart rate, blood pressure, dilates our eyes, etc., it also can cause some tremor. And beta blockers blunt the visceral reaction to stress. They can blunt the fight or flight response. So in doing so, propranolol can reduce tremor. At higher dosages, it can reduce heart rate and blood pressure. So it was originally designed as a blood pressure medication or a heart slowing medication, but because it's not as selective for the heart as other beta blockers, it fell out of favor amongst the cardiologists, and it's really more typically used by neurologists to manage tremor.
And now a message from our sponsor. The Think Neuro podcast is brought to you by Pacific Neuroscience Institute Foundation, a nonprofit 501c3 organization. If you're inspired by what you hear and wish to support our mission of education through innovation, please visit pacificneuro.org/foundation. So I have a friend who, when he's very nervous about public speaking, and before he goes and speaks, he takes a beta blocker.
Yes, I love the beta blockers for that purpose, for performance anxiety.
Why do we call them beta blockers? Is that just what's the beta that we're blocking?
The adrenaline, like epinephrine, the receptors are beta receptors.
They're beta receptors. So they're blocking the receptor, gather up this adrenaline. Okay, so that works. This is a drug that works for tremor.
Yes. And what I liked about them is that they can be used as needed. So a lot of my patients will notice a natural variability. They'll have more tremor one day and less the next. And they sometimes will be able to identify it. Oh, I had too much coffee, or I hadn't slept well, or I was stressed. And very commonly, they will have no rhyme or reason as to why they are having a bad tremor day. or they may have tremor that they can tolerate in many aspects of their lives, but they may not be able to tolerate it in other moments or activities. I had a patient who was a school photographer, and he was fine most of the time. But when he had those days that he was photographing, 300 kids, he needed to not have tremor those days. So he would just take his propranolol on those mornings. Or I might have somebody who has a little bit of tremor, again, when they're going out to dinner with their friends. And that's the only time that they will take the propranolol. So it can be used every day. It can be used up to 3 times a day. There is a long-acting form of it. But for people who prefer not to commit to taking a medication, propranolol is a nice option.
Any side effects?
Yes, everything has side effects.
So
because of those issues I was mentioning earlier with heart rate and blood pressure, there are some medications that it can interact with, and it can cause fatigue, dizziness, lightheadedness. So many people have difficulty tolerating propranolol. Unfortunately, with both propranolol and Primidone, which we'll talk about next, what we call the therapeutic window is too narrow. The therapeutic window is the dose at which the medication becomes effective. You want it to be a really low dose. And the dose at which it causes side effects, you want it to be really, really high. So you want to have this nice broad area of doses that the majority of people can tolerate. With propranolol and Primidone, it's a more narrow therapeutic window. The percentage of people who respond to a low dose isn't high enough. A lot of people need higher doses of the medication to really manage the tremor. And then the dose at which people get side effects is too low. So a lot of people will get side effects and have trouble tolerating propranolol and Primidone. That's not to say that they shouldn't be tried, because one doesn't know how they're going to tolerate until they tried it. And if one reads the side effect profile and they say, well, oh God, that sounds horrible, I don't want to try that. None of these side effects are permanent, and there's no withdrawal syndrome. So I always say it's worth a try, but I do have a lot of people who tell me, I just needed to know it wasn't Parkinson's. I don't want treatment. I'm tolerating the tremor. I'm handling it. So it's fairly common for somebody not to get treatment for essential tremor. And the other thing that's quote unquote nice is that because the medications aren't able to slow progression of the tremor, there's no need for people to take medication unless they feel that they want to. So I tell patients, this is a quality of life issue. This isn't a health issue. If you don't feel like the tremor is bothering you and you don't want to take medication, you don't have to take it. And if you come back to me in 5 years and say, Dr. Petrossian, my tremor's worse, I want to try something for it now, I'll say, okay, let's do that. I won't say, well, Mr. Effendry, you missed your opportunity and now it's too late. There's no window in that sense. You can start medication at any point, really. The other first-line medication for essential tremor is called Primidone. And that one was originally designed as an anti-seizure medication, but more typically it's used for managing essential tremor. Because it is an anti-seizure medication, it can cause dizziness, lightheadedness, drowsiness, fogginess, confusion, balance issues, slurred speech, double vision, and even emotional changes. None of which sounds good, but as I advise my patients, I always start them at a really, really teeny tiny dose, and then I very gradually increase the dose. And if they can't tolerate the medication, we just take them off of it. I would never ask my patients to trade the tremor for something equally bad like dizziness or fogginess. And again, it's what's weird about Primidone is that I find such a variability in tolerability. I have little old ladies who are taking 250 milligrams 3 times a day and tolerating it just fine. And then I have younger gentlemen who try 50 milligrams that it's just way too much for them. It just knocks them out. I actually have a funny anecdote. I had a patient who I advised him to start with a quarter of a pill. I advise all my patients to just start with a quarter of the pill. And the pills are really tiny. So he looked at it and he said, quarter of this tiny thing? What is Dr. Petrossian thinking? I'll just take the whole thing.
Oh, no.
And he was so knocked out the next day that he was like, oh, okay, she was right. Let me go back down to a quarter. So yeah, it's a very, it can be a very effective medication, but it does need to be taken every day, twice a day. And it takes a little bit of time getting used to it. And there are unfortunately a moderate percentage of patients who really just cannot tolerate the Primidone. So we have these two first-line medications, and there have been no advances made in managing the treatments, treatment of essential tremor medically. So now we move on to advanced treatment options.
1 second on this. I have to ask, Neurontin, Gabapentin is like prescribed for so many things. Is there any bearing here?
Yes, gabapentin, which is the generic for Neurontin, is used for essential tremor. It's one of those second or third line agents. I find that it's just a little bit less effective than the Primidone, but it's sort of on average more easy to tolerate gabapentin than Primidone.
Yeah.
So I do have patients who are taking it for tremor.
Yeah. It's
off-label, of course.
Well, there's so many off-label uses.
Almost everything for tremor, as far as medications, is off-label.
Off-label. Okay. Sorry. Go on.
So for patients who have a very concerning or disabling tremor and medications haven't worked for them, we talk about advanced treatment options for tremor, namely deep brain stimulation surgery, and now more recently, focused ultrasound. Deep brain stimulation, or DBS for short, has been used for tremor since 1996, something in the late 90s, 95, I think. So many decades, actually. DBS is not experimental. It's very well established as treatment for ET. And it's very effective. It reduces tremor by 70% on average. And for many patients, it's really dramatically an improvement in their quality of life. But it is brain surgery, and it does require the implantation of hardware, which is to say the electrodes go into those parts of the brain I was mentioning earlier, the tremor generators. And by stimulating those cells, paradoxically, we actually silence them. And we reduce the tremor generated by the thalami. And so DBS is best thought of as a pacemaker for the brain. And in the same way that a pacemaker would have a battery and implanted pulse generator underneath the skin of the chest, below the clavicle or collarbone, it's the same idea, except that instead of those wires going from the battery / pulse generator to the heart, the electrodes are going up to the brain and are implanted in both sides of the brain.
How do you get them into the brain?
DBS is a pacemaker for the brain, and just like a pacemaker for the heart, where there's an implanted pulse generator in the underneath the skin of the chest. The same concept is true for DBS, except that the electrodes go from the chest into the brain instead of into the heart.
How do you get the electrodes up into the brain?
Our colleague, Dr. Lanjavan, who's our neuromodulation brain surgeon, he is the director of neuromodulation at PNI. He creates two small holes into the skull. They are about the size, a little bit smaller than a quarter, one on each side. And then he advances the wires, the electrodes essentially, deep into the thalami, one on each side. And then he, what's called tunnels the electrodes underneath the skin behind the ear. And then the connection from that spot down gets screwed in here behind the ear, and then down again to be tunneled underneath the skin of the neck down to the pacemaker, which we usually place on the right side.
Okay. So that's a major,
we call it battery or IPG.
that's brain surgery.
It's brain surgery.
Yeah.
Yes.
So you must have a pretty serious case of essential tremor to warrant that kind of intervention.
That's right. Really a lot of people hear about it and they think to themselves, well, I'm tolerating this. I'll just rather live with it. One of the somewhat frustrating things, it's a double-edged sword, as it were. The good thing about essential tremor is that it's very slowly progressive. So many people can tolerate and live with it. I mean, they may not be happy about it, but they're finding a way to get by for decades. And their tremor may not get to a point where it's severe enough for them to feel that it's warranting DBS until they're in their 80s. And then when they're in their 80s, they think to themselves, I'm 80. I'm not going to go through brain surgery. We do have patients who go through DBS in their 80s, but most of our patients are not too keen on it at that age.
So what you mentioned targeted ultrasound.
Yeah, so focused ultrasound got FDA approved in 2016 for essential tremor. And that is a non-incisional brain procedure. So I don't like to use the term non-invasive because it is a brain procedure. You are making a change to the brain. So remember, we talked about those tremor generators of the brain being in the thalami. And so what focused ultrasound does is it takes about 1,000 beams of ultrasound to point to the VIM, that small nucleus of the thalamus. And by focusing 1,000 beams of ultrasound, it actually creates a heat lesion in the brain. The analogy I like to give is if you take a magnifying glass, you can focus the rays of the sun and burn a hole in a piece of paper. So that's the same thing that's happening in focused ultrasound for essential tremor. It's doing what's called a thalamotomy, meaning creating a small hole in the thalamus, except you're not doing it by physically going in, you're doing it from the outside in. Because of the fact that it can cause some slurred speech and gait issues, so far, focused ultrasound is only FDA approved for unilateral treatment. So the patient would have to choose which limb is more bothersome to them. Typically, their dominant hand.
Okay. And so you focus on that side. And how many beams?
I told you there's 2 thalami, one on each side. So there's a tremor generator on each side, and the surgeon can use the focused ultrasound to create a heat lesion on one thalamus, and then the opposite hand will reduce.
How many beams of ultrasound did you say you use?
About 1,000.
Is that a lot or a little? I mean, it's a lot. It probably
what?
Well, I don't know. I'm trying to understand the scale. I mean, it's enough to create a heat lesion pretty deep in your brain.
Yes.
Yeah.
Yeah. I mean, focused ultrasound is used for other things like treating kidney stones. And honestly, I don't know how many beams of ultrasound are used for that because I haven't looked into it. But the challenge of focused ultrasound was how do you get through the skull? And so that was the technology kind of landmark that was improved upon. And there are actually patients where they literally have too thick a skull for the ultrasound to work. So people do need to have a DAT scan before, as well as the MRI, before the procedure to make sure that they are a candidate.
But again, this is you have to be suffering pretty significantly from essential tremor to consider this, I'd imagine, right?
Yeah. I mean, I think some people who are not interested in DBS are going to be more willing to do focused ultrasound because of the appeal of the fact that there isn't any hardware, there aren't any incisions. You do get immediate results, which is really nice, but it is not modifiable.
That's it. It's your one shot.
Yes.
Okay.
For people who have sort of that window of, well, medications didn't work or the tremor's getting worse despite the medications, but they just don't feel like they're advanced enough to warrant DBS or focused ultrasound, there's this huge population of patients who need better treatment options. And one of the things that got FDA approved recently is a non-invasive peripheral neurostimulation device called Calatrio. And we were involved in one of the clinical trials that was looking at the efficacy of Calatrio a couple of years back. And it has been found to improve the tremor when people would wear this device on their wrist. It would create electrical stimulation alternating between the radial and the median nerves. And so that aspect of the fluctuation with flexion and extension, it goes back and forth between the nerves, right? So by actually measuring the frequency of the tremor, the device calculates when to provide that stimulation to accurately target first the radial, then the median nerves, and back and forth, back and forth. And the electrical stimulation, when it is worn by the patient controls how much stimulation to give themselves. But typically you would want to feel that buzzy kind of stimulation all the way down to your fingertip. And so it's sort of that thing where they choose how much they can tolerate. But they have to wear the device for 40 minutes twice a day. And in the trial, we found that there was a significant improvement in the tremor after they would wear these devices and use the stimulation. The extent of the benefit is, somewhat, it may vary from being mild to moderate. So let's say somebody has severe tremor, they may have an improvement down to having moderate tremor, or if they have moderate tremor, it might improve to being mild tremor. But it isn't necessarily eliminating tremor. Not that anything really eliminates tremor, any of our treatment options. The peripheral neurostimulation device, I think that the technology is really interesting, and it's definitely a nice option for patients to try because it's non-invasive. And if they feel like it's not working, they can, try it for a couple of months and send the device back.
How big is it? How big is the, what are we talking about?
It's kind of the size of a smartwatch, maybe a little bit bigger, a little bit wider. They actually did a pretty good job of the design of it, the look of it. So it's just,
it's convenient. It's not, you're not walking around with a giant brick-like thing on your arm for 40 minutes.
Everybody's a little different in terms of how they tolerate it. Some people would just wear it at home, for example, and then take it off. Some people might wear it. You can leave it on. Most people, I think, would take it off when they're not stimulating.
Got it. And the stimulation lasts. You get treatment effect even when the thing is not on.
That is the question. So unfortunately, I think the duration of the benefit from the stimulation is limited. So on average, in the trial that we were involved with, it was about 90 minutes of improvement. So really that's what I was saying earlier is that this is a technology that's really promising, but I think that a little bit of tweaking is necessary before it really can have a much broader impact. Because if we could get it to last 5 hours, then I think it would have a lot more patients who would be really excited about it.
Oh, sure.
Where it on average is 90 minutes, for some people, it's still got a good validity to it in that, let's say they use it before they go out to dinner and that kind of thing. But for many patients, they're going to want to see it lasting longer.
Sure.
So I think there's a lot of work that needs to be done, but it's certainly a nice option for patients who haven't been able to tolerate the medications, or the medications just stopped working for them and they're not ready yet to consider a more advanced treatment option.
It sounds like a very smart TENS unit.
It's a good example is that it is like a TENS unit, except that it's alternating, and it measures the tremor, which is really cool. And so they actually looked at the real world, like what were people doing in the real world? Because the FDA labeling says that the patient needs to wear it for 40 minutes twice a day. And so they had real world data of how much tremor they had and how much they were using it. And they found that some people were choosing to use it back to back instead of separating out their sessions 3 hours. So it raises this question of, are there people who can tolerate it and wear it longer and find that it works just by stimulating longer? We don't have data to be sure that that's safe to use it like that. But I think it's the concept of, this is an interesting technology. Patients will play around with it, and the company needs to, and possibly other companies as well, need to work on how to create improvements in the technology.
Sure. Okay.
So all that to be said, we have a lot of options for essential tremor, but we still need better choices. And first and foremost, we need better medications, because it's ridiculous. It's been decades since there's been anything new. And I'm not just talking about something new from a FDA approval perspective. I mean, us doctors, we're doing a lot of off-label this, off-label that. Nothing has been shown to be more effective than Propranolol and Primidone when it comes to even repurposing medications that have been FDA approved for other reasons.
Well, best of luck with that.
Thank you very much.
Yeah. Dr. Petrossian, it's been a pleasure again for having you on the podcast here, and we look forward to seeing you again. Thank you.
Thank you so much. Have a good rest of your day.